Hello, everyone. Welcome back. My name is Dr. Elizabeth Ortiz. I am a board-certified rheumatologist with over 15 years experience treating all kinds of rheumatology and autoimmune and inflammatory conditions. On this channel, I am dedicated to getting practical, truthful, and up-to-date information about all things autoimmunity and rheumatology to you so that you can make the best health decisions for you and your life. Today, we are talking about GERD, otherwise known as acid reflux. Although not really an autoimmune or rheumatologic issue, it is very common amongst those who have seen a rheumatologist and not always adequately addressed. So we're going to dive into all things acid reflux, why you have it, and how you can deal. All right, so what is GERD? So GERD, G-E-R-D, stands for Gastroesophageal Reflux Disease. It's simply reflux of the stuff in our stomach, which can be as unpleasant as it sounds. It's very common. In a recent study published in 2020, it was found that up to 44% of those in the US reported GERD symptoms. Are you in that 44%? Well, what are the symptoms? It's not always the feeling of heartburn or regurgitation, but can also include chronic cough, feeling of something stuck in our throat or a globus sensation, wheezing, sore throat, or sour taste in your mouth, or even lung issues. There are a number of things that will put you at risk for GERD. Using common anti-inflammatory drugs like NSAIDs, so ibuprofen, naproxen, smoking, and having a BMI of greater than 30 have all been found to put someone at risk. When focusing on those with autoimmune conditions, it's the use of the NSAIDs that can really lead to this problem. In almost all of our autoimmune and inflammatory conditions, where there is inflammatory pain, whether in the joints or the chest, we're going to recommend ibuprofen, naproxen, or similar medications. We do this because they cut down the inflammation and thus the symptoms, but they can also lead to new or worsening GERD. So how do we diagnose GERD? Well, initially, it's just based on symptoms, mostly heartburn. I say that because it is very common for the other non-obvious symptoms to be overlooked by patients and by doctors, unfortunately. So let's go over those atypical symptoms one more time, just to make sure that we remember them and can identify them if they ever happen to us. So chronic cough. This is more common than you would think. I've seen tons of patients go through chest x-rays and even allergy and ENT and pulmonary consults when really they just needed an antacid. Second one is this globus sensation. This is having a feeling that something is stuck in your throat. I can't necessarily speak to other specialties, but I've seen this in autoimmune patients a lot. And I've seen it poo-pooed as anxiety. It's true that mood disorders such as depression and anxiety can be seen with autoimmune conditions. And it's true that anxiety can show itself as this globus sensation. But that doesn't mean that all globus sensation is anxiety. The third symptom is the sore throat. When we have an autoimmune condition or are on medications that can manipulate our immune system, we can get scared of getting sick, whether it's catching a cold, the flu, or COVID. We can jump a little too fast at treating a sore throat as an infection. Even worse, when that sore throat doesn't go away or maybe keeps coming back, we can get scared we're having recurrent infections. The irritation from reflux can also lead to sore throats, and we need to keep that in mind. Okay, now there's wheezing and other lung issues. Although not as common, this still needs to be in our minds when evaluating anyone's symptoms. When we have reflux, that refluxed acid can come up our esophagus, into our throats, and then down our trachea or our windpipe. That can be very irritating to our lungs and lead to breathing issues. Now, you would think if something like that was happening, you would definitely feel the reflux. Well, not necessarily. So if this is being considered, we often need more tests to nail it down. Now, side note, the symptoms of heartburn do not correlate with how bad the reflux is. Someone can have horrible reflux symptoms and have little to no irritation seen on the esophagus. We call those erosions, and vice versa. Speaking of more tests, when do we do an endoscopy or EGD or scope? EGDs are usually not done right away because honestly, most of them are normal. The reason to get an EGD is either one, you have what we call red flag symptoms. So what are those? You can't swallow, you're having unintentional weight loss, you are vomiting or have evidence of bleeding. Or two, you've tried treatment with an antacid and it's just not touching you. Another time an EGD might be considered is you tried treatment and it worked, but then the symptoms came back. Or you're being evaluated for an anti-reflux surgery. And then finally, if there's a concern for cancer or cancer changes in your esophagus, they'll do an EGD. Now again, side note, if you fall into this category, you would know. It usually means you've been dealing with GERD for a while and possibly are already in the care of a gastroenterologist. It's very rare for someone without GERD before to suddenly get GERD related to cancer changes in the esophagus. So don't freak out, no need to worry. An endoscopy isn't the only test available. They can also do reflux testing, and I say they because this will be done by a GI doc. Either via a wired catheter or a wireless capsule, they can measure pH changes in your lower esophagus. Now, this is not something that is done routinely and will usually be done if you are a medical mystery, meaning they have tried all kinds of acid reducers and you are still having symptoms, or you are seeing a surgeon to talk about surgical options for your GERD and they are wanting to collect as much information about your esophagus before taking you to the operating room. Okay, so let's take a minute to focus on the autoimmune patient. We've gone over the common and not so common symptoms for GERD for everyone, including those with autoimmune conditions. But there are some points I want to specifically make to those of y'all with inflammatory conditions. NSAIDs like ibuprofen, naproxen, and steroids like prednisone can lead to GERD. They can both do it alone, but when taken together, even more so. On top of that, for most people on these medications, they will likely be on other medications, which can only exacerbate the issue. The nausea and heartburn that can develop can be very troublesome, especially when you have joint pain, fatigue, and a whole slew of other symptoms to deal with. If you find yourself in this position, do not stop all your medications. None of this, screw these medications are tearing me up. Instead, reach out to your doc or your nurse and simply tell them you're having stomach upset or heartburn and is there anything they can do. I'm telling you to bring this to their attention because there is something they can do. By adding an antacid or acid reducer, it can calm down your stomach's acid and reduce your symptoms. There may also be alternatives to your NSAIDs or prednisone that they can try to ease off your stomach. What? More medicine? This sucks. Yes, I know. But the truth is, if someone is in a state where they are needing a lot of NSAIDs or prednisone, it usually doesn't mean things are going well. Whether it's a flare or just having a lot of active inflammation, in those moments to calm things down, we are in an adding phase. Once things are calm, we can then start to peel away the meds, including the antacid. Okay, so I've mentioned it a couple times, but here, let's get into it. What do I mean when I'm saying antacid or acid reducer? Well, antacids are what we use for immediate relief. These are things like Maalox and Gaviscon or Tums. Now, just a side note, I don't typically like to use brand names here, but if I said alginate antacids or calcium carbonate, I'm afraid y'all wouldn't know what I meant. So, aside from antacids, there are two other categories of meds used for GERD. So the first one are the histamine 2 blockers or H2 blockers. The second one are proton pump inhibitors or PPIs. Now, H2 blockers are usually used for as-needed relief, or you can use them daily for mild to moderate GERD. They can also be added on top of PPIs in severe cases. So examples of H2 blockers are going to be ranitidine or Zantac, cimetidine, Tagamet, or famotidine, which is Pepcid. The other class are PPIs, and these are really the workhorses for GERD. They are the most effective and are used in those with moderate to severe symptoms or documented erosions on a scope. These are not as-needed meds. They really should be taken daily and sometimes twice daily. They should be taken 30 to 60 minutes before eating and preferably in the morning. So examples of these are going to be meds that end with the ol. So we're talking omeprazole, which is Prilosec, esomeprazole, which is Nexium, lansoprazole, Prevacid, or pantoprazole, Protonix. Each one has its own quirks, and based on how you respond, it may be recommended that you take one versus the other, but they largely all act the same and have the same benefit. We haven't really given you the steps to take when you or your doc think you have heartburn. It's really simple, actually. You talk about your symptoms, you decide that there is a high likelihood that you have heartburn, and you start a trial of a PPI. If your symptoms get better or go away, great. You most likely had reflux. Now you can focus on lifestyle changes so that you can get off the medication. If your symptoms don't get better, then it's probably time to talk about a scope. But what if your heartburn is due to all the freaking meds your rheumatologist gave you? Well, then you will usually be started on a PPI and will need to continue that PPI until the offending medication can be stopped. Once the problematic medicine is gone, or at least isn't needed as frequently, most people are able to decrease or completely stop their reflux med. Just like most things we talk about here, these aren't meds we necessarily want to be on forever. Long-term PPI use has been associated with increased risk of GI infections, bacterial overgrowth in the small bowel, as well as dementia and bone fractures. Basically things we just don't want to have to deal with. And this is so important to understand. I see all the time people get some heartburn, start over-the-counter meds, and just take them for years without thinking about it. We need to think about the meds we take, why we are taking them, and if they're really necessary. If you've been taking an over-the-counter heartburn medication for years and haven't talked about it with your doctor, please put it on your list to discuss next time. So this is an excellent segue to non-pharmaceutical means to control your GERD. I'm always going to recommend adding lifestyle measures when you have GERD, whether you are on prednisone with lupus or ibuprofen with osteoarthritis. So what can you do? Well, number one, avoid eating 3 hours before bedtime. And 2, avoid alcohol, caffeine, carbonated beverages, and smoking. 3, evaluate if there's room to lose some weight. Any amount can help. The 4th thing is elevate the head of the bed 6 to 8 inches. You can do this with a bed wedge or incline mattress, or even by putting cinder blocks under the legs of the head of your bed. Keep your meals small. Consider 4 to 5 meals instead of 3. Avoid spicy foods and high-fat meals, and try not to nap or sleep right after eating. We need gravity on our side, so keep it upright. Pay attention to foods that make it worse. Common culprits are peppermint, onion, citrus, juices, tomatoes, and chocolate. Make sure you are making enough saliva. Oh my God, I am talking to all you Sjogren's people out there. Saliva helps to neutralize acid reflux and can contribute if you naturally don't make enough. If this is you, and you have Sjogren's, rheumatoid arthritis, or lupus, talk with your rheumatologist or your doctor about what you can do to encourage more saliva production. Finally, evaluate for ways to reduce stress, as if that was easy. All right, so I love giving you some information to chew on, things to think about, and take to your next doctor's appointment to kind of continue the conversation. So, have you been having heartburn, an unanswered chronic cough, or sore throat without an explanation? Could this be GERD? Shoot your doc or nurse a message and ask. Are there any foods you notice trigger these symptoms? Think about spicy foods, fatty foods, tomatoes, citrus, or chocolate. Are you currently on an acid reducer medication? How long have you been on it? Do you still need it? If it's been a while, add it to your list to discuss with your doctor at your next visit. Okay, folks, so that's my take on GERD. Now, this is from a rheumatologist point of view. Again, we see this all the time in our patients, whether it's from their actual condition like scleroderma or Sjogren's, or from their medications. GERD is very prevalent in our offices, and we need to be doing a better job at handling it. I want to add a quick thank you to a dear friend, Dr. Douglas Wine. He's an excellent GI in Jersey and an old friend from my med school days. If you happen to have any GI problems and are in New Jersey, look them up and tell them Dr. Ortiz sent you. So I hope this has helped. I hope you've gotten a little more understanding about GERD and maybe some information to tackle it or to talk with your doctor at your next visit. If you like this, found it helpful, please like and subscribe. It really helps out the channel. Share it with anyone you think could benefit from this information. Like I said, my goal here is to provide practical, up-to-date information for you to take with you to your doctor's office and make the best decisions for your health and your life. Thanks, and have a great day.